Now this is the most awaited session of the day, slide seminar. For this, we have with us legendary, doyen, and a person with international repute, Dr. Anita Borges, Madam. She is a person who has virtually grinded pathology, minced it, and digested it. And that's what makes her an international authority in the field of pathology. And let us concentrate. As a single word from her is, after 40 years of experience with diseases, pathology, and microscopy. You must have seen slides sent by her online. Moreover, today, PG students have a chance to show their mettle when ma'am pops up with her array of spot diagnosis. I request Dr. Anita ma'am to start her lecture.
Thank you. Thank you very much. We have 6 slides that were circulated, and I hope most of you have seen it on the website. And then there are fillers in between, which are really spot diagnoses. Okay, so yesterday I met a group of young PG students from Ahmedabad, and I took down their names, and they must have spent a sleepless night, but I'm not going to call you, okay? So just relax. See, they're all sitting over there wondering and biting their fingernails. And anybody and everybody is sort of okay, invited to give whatever their thoughts are. So let's start with case number 1, and this was it. It's a 32-year-old male who had multiple cutaneous nodules around the great toe. I'm sure all of you know that this is a soft tissue sort of slide seminar, because all of these lesions have been found in the soft tissue. So here is the history, and this is the low power view of this. And I don't need to describe it, but you can see that it is very certainly cutaneous. And this is in the upper dermis. It's a biopsy, so you don't see the lower margin of this lesion. And when you go to sort of a medium power on this lesion, sorry, yeah, it's okay. Medium power on this lesion. I'm not going to describe this. You all have seen it. So I'll go very rapidly through the slides. Okay? But you can see that it's composed of very pink-looking elongated cells. There is another view of the same thing, and another view, and you can see how large some of these cells are. Some of them have eccentric nuclei and the cytoplasm flowing away from it. If you look at the nuclei themselves, you can see that they're vesicular, and many of them have got nucleoli. Here's another view of the same thing, another view of the same thing, and this is what, when there is something in the soft tissue, this is the way that I approach the diagnosis. Okay, so this is the first case, and we can go through the motions as to how we will go about it. But did anybody come to any kind of conclusion on this? Would anybody in the audience like to say something about what they thought this particular lesion was? All right, as we go down these questions, any case, whether it is, in this case we're discussing soft tissues, there is a certain thought process that goes through one's mind. Now, everybody's thought process is not the same. I have a thought process. I'm sure several of the very senior people in this audience over the years have developed their own approaches to diagnosis. But I know very well, because I do a lot of teaching in different parts of this country, that the young people have not developed a thought process, and many of them never will, because they have just one idea in their minds, and that is, what's the diagnosis? That's all. And when you have just that what's the diagnosis in your head, everything else gets blanked out. You don't even make appropriate observations. And I'll just say it now, and I reiterate it every time I talk to young people, and that is, without good observations, both positive and negative observations, you cannot make an interpretation. And if you have a good observation, your interpretations may be not just one. You can have 2, 3, 4 different interpretations of the same base of observations. Then you may need additional information, and ultimately you build some scenarios. And this requires not just looking at something, making observations, and hoping that you will arrive at a diagnosis. It needs an analytical approach. There are very few amongst us who have done so much analysis right from the time that they were young as diagnosticians to the time that they have now reached, that this analytical process is compressed to such a degree that you can look, your mind analyzes, and you come out with a diagnosis. That is really very few, those who are extremely experienced, okay? But therefore you must have a system of analysis. Now, I'm just giving you my system of analysis. You may have other systems. Your teachers may have other systems, and you learn from so many different people, from so many different experiences, because pathology is no different from life. You learn as you go along. All right, now as far as soft tissue lesions are concerned, this is one of the, one system that I am offering you. And this is, if you can see here, this is number 1, and that is first thing in the soft tissue, because there's so many reactive conditions, right? So is this a tumor or a reactive condition? That you have to decide after you have made your observations. You may not always know. The answer may be yes, no, or maybe. That's also a way of coming to something. If it is a tumor, all right, then what is its morphological type? And this is something that we need to consciously think about. Is it epithelioid? Is it mesenchymal? And mesenchymal does not mean always spindly, okay? Because spindle is a particular type of cell. Not all mesenchymal cells are spindle-shaped. Is it biphasic? That means it's both epithelioid and mesenchymal. Is it round cell? Is it pleomorphic or polymorphic? Monomorphic. That's very important, yeah? And it doesn't fit into any of these. It may be some other type which you are just not able to, sort of put in. And finally, of course, you come to the next step, and that is it benign or malignant? And if it is malignant, most people think, oh, it's malignant, it's in the soft tissues, it must be a sarcoma. No. Always ask yourself whether this is a soft tissue tumor, or it is a tumor in the salivary gland, or a tumor anywhere else, and particularly in organs which are drainage areas for malignant tumors like the lung and the liver. Just because a tumor has been removed from the liver or from the lung, it doesn't mean that it's primary over there. So the next question after malignant is not what is it it primary or secondary, all right? And finally, when you have done this sort of analysis, then you see, can I make a diagnosis based on checking off all these boxes? Is it possible? Or do I require some ancillary tests? Okay, so that's my way of working it out, and because I'm standing up on the stage now, you have to bear with my way of analyzing this case. All right. So, if I asked, is this a tumor or a reactive condition, what would you say? Is it a reactive condition? The answer is no. No, it's a tumor. And is it epithelioid? No, I don't think so. Is it biphasic, round cell, monomorphic, pleomorphic, or other? It's mesenchymal. Is it spindly? Anybody want to answer that question? Those people who are sitting there at the back who were so excited about getting the prizes. Okay, my commiserations to those who didn't get the prizes, but prizes are always, 2 or 3, right? So, tell me, is it spindly? You saw the case. Yes or no? I hear some yes, and I hear some no. Just remember one thing, you guys at the back. Any and every elongated a cell with an elongated cytoplasm is not a spindle cell. A spindle cell is defined by its nucleus, a nucleus that has a length that is more than twice its breadth. So it's the nucleus that defines a spindle cell, because you cannot fit a spindle nucleus into a cell that is either round or cuboidal or polygonal or stellate. Yeah, a spindle nucleus will only fit in an elongated cell. But every elongated cell does not have to have a spindle nucleus. It can have a nucleus at one pole. The nucleus may be round, it may be irregular, it may be centrally situated, but it does not have to be spindle. So a spindle cell must have a spindle nucleus. I beg the sort of indulgence of those who are sitting in the front rows, because you know all this. I'm talking or preaching to the guys who are sitting at the back. All right, now what's the next question we have to ask? So we've said what the morphological type is. Do you think it's benign or malignant? Benign or malignant? Benign. I don't think so. Did you see the nuclei of those cells? Oh, they're huge. They've got nucleoli. And if you looked around, okay, you didn't see too many mitotic figures, but it would be hard to think of some benign tumor in the soft tissues that would have this much nuclear pleomorphism. All right? So if I had to make a choice, and I'm doing interpretation now after I have made observations, I would say that this is probably malignant. Now, if it is malignant, is it primary or secondary? Primary. There are multiple nodules on the skin. Do you think it could be secondary? Yes? Yeah, except that it's not all over the skin. It's all concentrated. It's actually near the toes, so it's all concentrated in one site. Now that's very odd. If you get multiple metastases, it's in different parts of the skin, and they don't all concentrate around one area. You can get one nodule in one area, maybe at the most two, but when you get multiple nodules, you have to really put secondaries or metastatic disease a little low down in this thing. So, all right, it's primary. Now, do you think you can make a diagnosis? Is it possible? Or do you need ancillary tests? What? I don't think it's very possible, right? It's not an easy case. It probably requires ancillary tests. Okay. So the next thing is, now you have done some analysis, and you have to have some thoughts after having your observations and done some kind of analysis as to what kind of scenario you are going to build. And I like to do something every time I look at any case, whether it's benign, malignant, whether it's neoplastic or non-neoplastic, and that is, in my mind, make a short summary. How can I, in one or two sentences, say everything about the case that I have seen, okay? And so I'm doing the exercise for you now, and that is, if I have to encapsulate what I know and what I've seen about this case, I would say this. And if anybody has any other things to add, please feel free to do that. I would say that, what do I know about this tumor? Multiple cutaneous tumor nodules, yes, that was a given, in the distal extremity of an adult, it's not a child, yeah, with a distinct rhabdoid morphology. It was pink. It had those cytoplasm that was flowing. There are very few cells that are so pink as when you have muscle in it, okay? Smooth muscle also is very pink. Skeletal muscle is very pink, but this doesn't look like smooth muscle, right? Because smooth muscle tumors, unless they're very pleomorphic, have what kind of cells? Spindle cells. Yes or no? A smooth muscle tumor is a spindle cell tumor. All right, so rhabdoid morphology. And then you think, hey, this has rhabdoid morphology. Could it be a rhabdomyosarcoma? No. In your mind, you think it is an unusual presentation for a true rhabdomyosarcoma. You know, to get multiple cutaneous nodules. It's not a soft tissue thing in the subcutaneous or in the deep muscle. It is there, right under the skin. So you have encapsulated what you know about this tumor. Now, sometimes if you don't know what something is, you should also think about what? You have to eliminate some things, right? So you don't know what it is, at least you can say what it is not. So what is it not? It's not a lymphoma. It's unlikely to be a carcinoma or to be a melanoma, although we say, you know, that melanomas can look like anything, and this one did have some large cells, but it had this very pink cytoplasm, eccentrically placed nuclei, and anything can look like anything, but we are dealing with probabilities. Any diagnosis, whether it is histological, cytological, or any other clinical, radiological diagnosis, is based on probabilities, and that means what is the chance of this being this rather than that. And if that chance is higher, then that is the probability that we will chase. We do this all of the time. That's what empiricism is all about. Next, what do you say? It's not this, it's unlikely to be this, it's unlikely to be this. So you come to the conclusion that if it is malignant, it's in the soft tissues, it's probably a sarcoma. You agree with me? Yes or no? Yes, very good. But there is a third thought that is in your head. It doesn't look like any of the sarcomas that we normally come across. Okay, and we said that it is unlikely to be a rhabdomyosarcoma. It's just an odd-looking tumor. But it is so odd-looking that it seems that it must be characteristic of whatever it is. The only thing is, you can't think of what it is at that particular moment of time, okay? So what do? You have to do some ancillary tests, and whenever I have something in the soft tissues, these are the 4 markers that I normally do for things in the soft tissues. That's smooth muscle actin, desmin, CD34, S100 protein. And if I don't get any joy out of that, or I'm not getting any pointers, then I usually add cytokeratin and an EMA. And if I don't get any joy out of that, then I go to Google, right? And what do I say? And I tell you, you laugh. But it's amazing how often when you have something that is, you feel is characteristic of whatever it is, but you don't know about it, or you cannot remember having seen a case like this, if you put something like this, multiple cutaneous nodules, adult, distal extremity, rhabdoid morphology, and you hit the search button in Google, it's amazing how often you will find the diagnosis. 1 or 2 or whatever, it'll come up in Google. And then you can proceed to see whether those entities that have popped up on Google fit your case. But anyway, let's do the exercise, all right? Now here is our desmin, and here is smooth muscle actin, and you can see that both of them are negative. So it looks very pink, it looks like it should be muscle, but there is no smooth muscle, and there is no. Well, the S100 protein and CD34 are also negative. So now, what's the next step? CK and EMA. Very good. Hey, and when we put up the CK and EMA, see what you get. The CK is very definitely positive. There's no 2 ways about that. You can even see those very odd-looking shape cells, etc., have all taken on CK, and there is EMA. Now should we go back and think something else? Why is there no SMA, desmin, CD34, S100 protein, and now suddenly the CK has come positive? So what does the CK mean? Of course, there is no EMA. So what does CK mean? That there is something that is expressing some kind of epithelioid marker, but does that make it an epithelial tumor? What do you say? Everything that expresses CK, is it an epithelial tumor, particularly if it is in the soft tissues? Yes or no? No, not absolutely yes. You can't call something that has CK. Just usual normal myofibroblasts are CK positive. So don't get fooled by CK being present over there. Epithelioid sarcomas are CK positive. Synovial sarcoma can be CK positive, more often EMA positive, sometimes both positive. Okay, so there are many things in the soft tissues that are not carcinomas or not of epithelial derivation that are CK positive. On the other hand, there are carcinomas that look like sarcomas, yes? And you get sarcomatoid carcinomas. So they may show you CK, they may not show you EMA, they may show you CK which is very spotty here and there, but they look like sarcomas and they express CK. So now do you think that this is a sarcomatoid carcinoma and that our original impression that this is a primary tumor over there, that this may be a metastasis from some sarcomatoid carcinoma? Do you think we should revisit that whole thing? The answer is probably not, right? Let's see if there are any CK expressing tumors in the soft tissues that of course, they look like they are sarcomas and they express CK. So we said epithelioid sarcoma. Is it? Yeah, possible. Okay. Normally, epithelioid sarcomas express CK, they express EMA, they express CD34, and they often lose INI1. You know, INI1 is that its gene which is lost in some, the protein is not expressed in some kind of tumors, the most common one being the malignant rhabdoid tumor. So is this a malignant rhabdoid tumor? Well, we don't know, but let's see. Okay, so now let's check. That's INI1. Is it retained or is it lost? Oh, it's retained. You can see all these cells that are over there. They're all retained, okay? So INI1 is retained in this tumor. So it is not something like that malignant rhabdoid tumor, although this doesn't look like a malignant rhabdoid tumor in the usual, the usual kind of histological pattern. So now we have CK and we have got retention of INI1 and we don't have any CD34 and there is no EMA, right? Is there any other sarcoma that might express CK? Anybody who might know which other sarcoma that expresses CK? Well, there are some angiosarcomas or vascular tumors that express CK. So, but you say, hey, but there's no CD34. But CD34 is not always expressed by vascular tumors. So let's check whether this is a vascular tumor. We don't think that this is at least we've tested for an epithelioid sarcoma. And if everything else fails, we might come back to think, is this an epithelioid sarcoma? Or go to our ultimate port of call, and that is Google, okay? So now let's see. CD34, I told you, was negative. You can see that. But just look at CD31. It's being expressed by this tumor. Now that CD31 is a vascular marker. It's also a marker of histiocytes. Never believe that anything is specific for something as far as immunohistochemistry is concerned, okay? So how will we check whether this really means that it is a vascular marker? What's the third marker that we can use to be certain or to rule out vascular endothelial origin? Anybody? The marker is ERG. Okay, ERG. And now you see, it's full of ERG. So the 31 was giving us the clue. So this is a CD34 negative vascular endothelial cell marker. Not only marker, it's a tumor. And then we say, God, this doesn't look like any angiosarcoma or hemangioendothelioma that I know of. What is this peculiar tumor? Well, it's this. Okay? It's a recently described entity, so I don't expect any of you to know it. But once you have seen a case, and it is so typical because the description is in its name, and that is pseudomyogenic. It looked myogenic or not? Yes. So pseudomyogenic. Oh, something's happened to this thing. It's gone. Anyway, just as, excuse me, this has popped off. Pseudomyogenic hemangioendothelioma, because it has vascular markers. And this is distinctive. I told you that when you looked at it, you felt that this is distinctive. This is characteristic of something, only I don't know what it is, okay? So a distinctive, often multicentric tumor with indolent behavior. That's why you didn't see too many mitotic figures. And that tells you what the different characteristics of this tumor are. It's crops of nodules on the skin, spindled or epithelioid cells which appear like rhabdomyoblasts. There are stromal neutrophils, no necrosis. There weren't too many stromal neutrophils in this particular tumor. And you see that. It is CK positive, almost invariably CK positive, ERG positive. It is CD31 plus or minus. EMA, Desmin, CD34, and SMA are not expressed. So it doesn't express CD34. It may or may not express 31, but it is always ERG positive, and INI1 expression is intact. So what is our diagnosis? Pseudomyogenic hemangioendothelioma. The purpose was not to show how clever I was and making this diagnosis. Okay? Thank you. It is that there are things that we don't know. Unless you have come across it. This is not a very common tumor, all right? It was buried among so many other tumors until people began to do data analysis, and they found, hey, I've seen this before, and it was also in the skin, and it also had these crops of nodules. Now let's see what these things are, and they have been pulled out of either untyped cases or cases that were called something else. And these slowly build up our repertoire of what this is. But why is it important for us to know? Because this looks like a rhabdomyosarcoma, which is a tumor which needs chemotherapy, which needs radiation therapy. This is an indolent tumor and probably just requires good local excision. That's the reason I'm putting it up here, and I put it up as the first case, not to get you so dispirited and say, oh, what's the point? I will never learn how to diagnose soft tissue tumors. But there is an approach to every problem, and as I told you, if you had put, just see this, if you had put this into Google, you would have got the first article popping up over there would have said pseudomyogenic hemangioendothelioma. Okay? That is what I'm talking about. Now, this one you didn't see, but somebody at the back is going to have to make this diagnosis. A 63-year-old female lawyer underwent hip replacement surgery, right? And the femoral head was received by us for histopathological examination. Actually, it came out all in bits and pieces. And she was being treated for a long time for joint diseases, which was diagnosed as rheumatoid arthritis, of the knees and the shoulders. And she also had an eczema-like many lesions on the skin, and she was using some non-allopathic medication for many years. And I'm just going to show you the pictures, and there is only one diagnosis, okay? I use the word there as well. Shard. Anybody know what is a shard? You know, if you take a piece of glass and you smash it, you get bits of glass, right? And some of them are like this, dagger-shaped. You can actually kill somebody by stabbing somebody with it. That's known as a shard, okay? So what's the diagnosis? Quick! Quick! What are you seeing here? What are these fragments? Oh, back it's gone. This thing has popped off again. Excuse me, it's popped off. So, what is this? These pieces of tissue. Sorry, what is it? Didn't you see that they were black? Look at this. So this is ochronosis. Okay, and this is cartilage. You never see cartilage like this. You can see that this is a decalced cartilage. And how does decalced cartilage look? You can see because there's bone that is decalcified over here. So how does decalcified cartilage look? What color is it? Come on, young people at the back. What color is decalcified cartilage? Hey, can you... Huh? Green. What color? What color is it? Hey, don't tell me you haven't seen cartilage. What does it look like? It's blue. Does this cartilage, and you don't think that this is cartilage? This is cartilage, folks. You can see the lacunae over there. And it's black as hell. And these are like shards. Look at them. So this, my friends, is ochronosis, also known as ochronotic arthropathy. Okay? And what is it? You know that it's a metabolic disorder in which you get homogenesic acid accumulating in the tissues. It's a connective tissue disorder. And it is usually associated with alkaptonuria. You know that. Yeah? But sometimes you get it by using some exogenous creams and so on, particularly, and this is for the young people over there, skin whitening creams and hair dyes. They contain phenolic, hydroquinonic compounds, which, if they are absorbed in large amounts, depending on how much you're using and in what parts of your skin, you can end up getting ochronotic arthropathy. Okay? So this is ochronotic arthropathy. Very good. It's rare, you don't often see it, so I thought it would be worth putting it in. All right, we come to number 2, and that is a 22-year-old male with a lump at the wrist. Okay? Here you see this. Reasonably well circumscribed. Okay? Look carefully at this because you have seen it. This is a very low power view. I'm just showing you the periphery. Now I'm coming to the center. Look at it very carefully. Because if I start describing it, and you know the essence of a good description, and I tell this to young people all of the time, the essence of a good description is to be able to put all the positive and negative observations in a succinct kind of way to somebody who hasn't seen the case, and that somebody makes a diagnosis. Which means that you have absorbed all the important elements in the case, absorbed it for your own diagnostic purposes, and now you communicate that to somebody else, and that somebody says, hey, this is the diagnosis. So practice it every day. You're looking at slides, describe the slide so that somebody else who hasn't seen the slide can make the diagnosis, and then you are going to be okay. And now here is the periphery again, and let's look into the tumor, and this is what it looks like. Periphery and the tumor. Periphery and the tumor. So, anybody came up with any diagnosis at all? Sorry? Very good. Whoever did that made the right observations. Yes, it's an angiomatoid fibrous histiocytoma. I don't know where Prashant is. If he's busily giving out gifts and presents, this person does need it. Who's the young lady who made it because of the young lady's voice? Oh, she says she's not young. You think you're older than I am? No. Okay. Then you're young. Okay, right. Now, again, if we go to the approach to the diagnosis, it's a tumor. What happened? It went back. Okay. Yes, it's a tumor. Is it morphological type? you would say mesenchymal, but again it is not spindly, okay? And when you go down and you ask yourself, is it benign or malignant? And the answer is, I honestly cannot tell. I don't know. Is that an honest admission or not? I don't know. Unless I know the diagnosis, I won't know whether it's benign or malignant. Is it primary or secondary? Because I don't know whether it's that it's malignant. I can't ask the question, is it primary or secondary? But is the final diagnosis possible? And the answer is yes. Why is it yes? For the same reason that, sorry, what's your name, young lady? Vasudha. Same reason that Vasudha made the diagnosis, because it is absolutely characteristic of whatever it is. Okay? So the thoughts again, it's a tumor in an extremity of a young individual. It has a central unlined slit-like process. Space. Did anybody see that? Yes, you did? A bit of it is over here, but there were other bits of it as well. There it is. Okay, and it sometimes has blood in it, yes. So we had that. Yes, and then there was lymphoid tissue and lymphoid nodules at the periphery. And the thing was plump, either spindle cells with bland nuclei or just polygonal cells. And there's no immunohistochemistry that was needed or even helpful. Okay, the diagnosis was exactly what Vasudha said. It is an angiomatoid fibrous histiocytoma. It's a book picture. I'm not suggesting that you go and match pictures in the book. But here is another lesion that if you know it exists, yeah, or if you have seen it before, which I have, then you will be able to make this diagnosis. If you start to do immunohistochemistry, you'll go down the wrong path, because all of these tumors, or the majority of them, will show you desmin, and these are nothing to do with muscle. You see these peculiar cells with dendritic processes that are desmin positive, and people call these things, or say that they have myogenic differentiation in their reports, but this is not at all true. This is an angiomatoid fibrous histiocytoma. So if you want to prove it by anything, it's not by immunohistochemistry. The test that will be confirmatory is either you do a PCR, yes, in which you show the EWS CREB1 translocation, or if you don't want to do this, you can do what is called a break-apart probe, a break-apart FISH for EWS. But when you do a break-apart FISH, you show that EWS has broken apart from its original place and has gone somewhere else, but you don't know where that somewhere else is. When you do a PCR, you know what is the partner, and that is EWS CREB1. So that is an angiomatoid fibrous histiocytoma. Very good, Vasudha. Excellent. All right, now here comes the case which you haven't seen, and that's a 37-year-old male. It's a soft tissue mass over the scapular region. And I'm just going to show you pictures. You can see over here that, what is this? Skeletal muscle, okay? Skeletal muscle, and there is an infiltrative lesion within skeletal muscle. Young people at the back, is this a spindle cell lesion? Wrong. It is not a spindle cell lesion. You think these nuclei are spindly? Yes, some of them are spindly, but you think most of them are? Look at this nucleus. These are stellate cells. Look at the nuclei. These are not spindle nuclei. And if you don't notice this, young people, you will not get the diagnosis. I know what diagnosis was going through your heads. Can you tell me? I see wavy structures. Yes, so what was the diagnosis? I know it. Why do you think I kept it? It's not a neurofibroma, my dear friends. These are stellate cells. And you notice that because the nuclei are not spindly, for God's sake. Look at no neurofibroma has got these kind of nuclei. It doesn't have. They're thin, elongated nuclei. So waviness, the most wavy thing on God's earth is your tendon. And I have seen more young people calling tendon nerve, okay, than I don't know where else. So everything that's wavy is not neurofibroma or is not nerve. Okay, very good. So this is stellate. It's infiltrating skeletal muscle. So what is that stellate tumor that infiltrates skeletal muscle? Anybody? Vasudha? Huh? There, see? She's the soft tissue expert of Gujarat. It's a desmoid fibromatosis, which 9 out of 10 students will call a neurofibroma. Okay? This is a typical desmoid fibromatosis. Okay, so go back next time and look at desmoid fibromatosis and you'll know what it is. All right, we come to case number 3. This is a 30-year-old female. And this was excision, you saw the slides, excision of a painful 3-centimeter mass in the supraclavicular fossa. See? Okay. Very blue. Is that mine? I hope not. Oh. Look at this. And pay a lot of attention. I'm sure you've seen it, but I'm just showing you. So now, Vasudha, the tension is, everybody's eyes are on you. Because you have been crowned the soft tissue queen of Gujarat. Lots and lots of, see, lots. Right, so anybody came to any conclusion? Who said that? What's your name, young lady? She's saying, no, you have a name, don't you? The lady in the green with a red dupatta, what's your name? Huh? Shilpa. Aye, Shilpa is very right. This is a schwannoma, okay? Very good. From which college are you, Shilpa? Rajkot. Very good. So, if we go through this, is it a tumor? Yes. It's mesenchymal, but mainly spindly. And you saw sheets where there were no spindle cells, because those were the sheets that were cut at transversely. Okay. So, benign malignant, it's so cellular, so you say, I don't know if you don't know the diagnosis, and this has popped off again. So, it seems to be something wrong with the, all right. So, is it, we don't know, but the diagnosis is more than possible. And if you look again, you'll see what are the diagnostic features. It's this. See? You've got thrombosed blood vessels. You have a sharply circumscribed, even encapsulated tumor. Okay? You see, these are the spindle cells, and this is what it looks like when it's cut at right angles, and you can see palisading. You saw it. It's very subtle, but it's there. Okay? And when you want to make a summary, see at the top, it was painful. Painful, circumscribed, almost encapsulated cellular spindle cell tumor with some loose areas, hyalinized and thrombosed blood vessels, and focal nuclear palisading. You don't have to put it into the Google, just put it into your own higher center. Okay? You know what amuses me? I see so many reports. So-and-so, 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 big description, and they please refer to a higher center. You know which higher center you need to refer it to? Your own higher center. Okay? So you do this, and it will tell you. Just like Shilpa referred it to her higher center. So now you've got competition, Vasudha, from Shilpa. What's happened to all the men? No men competing over here? I always knew if we actually pay homage to Saraswati as the goddess of knowledge and wisdom. I hope you know that Saraswati is a goddess, right? Yes. So who are we paying homage to? Women. And nobody mentioned all the, whether it's epigenetics or genetics that was being discussed. that mitochondrial DNA contains most of the genes for intelligence. Okay, and where does the mitochondrial DNA come from? Doesn't come from the sperm. So, there you are. The sperm has no cytoplasm. So that's it. Okay, very good. So, right. So, the diagnosis is a schwannoma with some degenerative changes. Right, now here is a scrotal swelling in a 1-year-old male child. You haven't seen this. But it is so typical, so typical. Yes? Somebody can tell me what you see in this particular slide, and I don't need to put any other slides, just this one slide. I'll show you the other slides, but what do you see in these three, in this slide? Not these three, in this slide. Yes? What's this? Adipose tissue. What's this pink thing? Fibrous tissue, right? Yes. And you see some myxoid areas there that look less mature. So you've got 3 elements here. Fat, mature fibrous tissue, but fibroblastic tissue because it's not only collagen. And you've got immature tissue that is myxoid. So what is that condition? Where you get 3 things in a child. May not be in the scrotum, usually it is somewhere else. Yes? Teratoma. Hey. Now those were male voices, I'm sorry to say. Okay? Male voices, I'm very sorry to say. Yes, it's an infantile fibrous hamartoma or a fibrous hamartoma of infancy. All three things. It's absolutely typical. Again, characteristic. See, the fibrous tissue, the immature tissue in the middle, and you can see fat. Okay, so the diagnosis is fibrous hamartoma of infancy. Now, let's come to case number 4. How are we doing for time? Okay? Yes? Okay. Right. Now, here is what you guys have actually seen. It's a 20-year-old female who underwent a bowel resection, okay, following detection of a lump in the abdomen on ultrasound and CT. And the outside histopathology report mentioned a maximum tumor size of 5 centimeters, and the lymph nodes were metastatic. So they resected the bowel because the patient was both obstructed and had a mass. Right, and this is it. This is the low power. If you can see at the top, there's a very attenuated lining of the gut wall. The epithelium is, and you can see here, when you get to higher power, thank you so much. I'm sorry that I'm bothering you. All right, what do you see? Oh, you see, because we have to construct a short summary of what we see. So I hope you're constructing it in your head. You see this kind of, not clear cut, but somewhat packaging. If there is any stroma at all, it is a vascular kind of stroma. This is not a sinusoidal stroma. This is not what we call an organoid pattern that you see in paragangliomas and many endocrine tumors, okay? Sinuses or sinusoids do not have a wall. Each of these has got a wall, okay? Sinusoids just have an endothelium with a basement membrane, and that basement membrane is usually perforated, okay? Like sinusoids in the spleen or in the liver or whatever else. So this is vascularized with the thin vessels. You can see some vague kind of nesting. But look at the cells. And how will you describe these cells? I hope you're describing them in your head, and you can see the vesicular nuclei, very small nucleoli. There's nothing that hits you in the eye, but when you go down, you see that the cells have got a lot of cytoplasm, yeah? But that cytoplasm is not taking up a good eosin stain. So what do we say about these kind of cytoplasms? That they are clear. Very good. I put the words in your mouth, yeah? Okay. So you can see that. There is a clear cell tumor and this is the lymph node metastasis over here. So, anybody with a diagnosis? See? I tell you, female voice again. Female voice. And we will go through the same old approach to the diagnosis. Yes, we know it's malignant. Why do we know it's malignant? Because there were lymph node metastases, my friend. You don't get benign tumors with lymph node metastasis. We know it's primary because there's nothing else anywhere else, and we do ancillary tests. So if I had to construct something, I would say malignant tumor in the small intestine consisting of nests of clear or eosinophilic cells with a fine fibrovascular stroma. Nuclei, vesicular, mild pleomorphism, or no pleomorphism at all, and small nuclei. So what's the differential diagnosis? You have to rule out these things. Epithelioid GIST, epithelioid smooth muscle tumor, PCOMA, you know that, no? What is it? Perivascular epithelial tumor, right? Carcinoma, melanoma. All of these come into the differential diagnosis. So we do all this immunohistochemistry. It's not c-KIT positive, it's not CD34 positive. CD117 is, that's done. There was DOG1 is negative in this case. There is no CK, but there is epithelial membrane antigen being expressed. And then S100 protein, you know that we do all these for soft tissue tumors, very strong, but no HMB45 and melan A. Now that, my folks, my friends, is a very, very odd thing. Yeah? If you have neurogenic sarcoma, it should be S100 protein positive, and you don't have to get HMB45 or melan A positive. So is this, it's malignant, so is it an MPNST, a malignant peripheral nerve sheath tumor? Doesn't look like the usual ones. Is it an epithelioid variant of malignant peripheral nerve sheath tumor? But actually what it looks like the clear cell sarcoma that you get in the extremities. No, it was nesting, it was clear, it had some small nucleoli, and it is S100 protein positive, but all those clear cell sarcomas also express one or the other marker of melanocytic lineage, and that is HMB45 and melan A. This one did not. So these are the positive stains, and these are all the negative stains, and none of this. We also have this antibody, and that is the microphthalmia transcription factor, MITF, which is expressed in all melanocytic tumors and lots of other, some other tumors as well, including PCOMAs and stuff like that. Okay, so now what test? If this is a clear cell neuroectodermal tumor of the gut, then what test is diagnostic? Who said that? Clear cell neuroectodermal tumor? Oh, there you are. I told you, the queen. The queen, very good. So what test would you do? Yes, so we did that. And you have an EWS-R1, ATF1. You can get one or the other. So we tested for both. So this is the clear cell sarcoma-like tumor of the gastrointestinal tract. Okay? Very malignant tumor. Doesn't look malignant, but there are very few patients who have survived this, okay? There is no doubt, and here it is. Malignant gastrointestinal neuroectodermal tumor, and it has a molecular analysis. The clear cell sarcoma of the tendon sheets also has this translocation, but this tumor never shows you HMB45, melan A, or microphthalma transcription factor. So this was published in 2012. So very good. Her name is Vasudha.
Ma'am, she's an additional professor in the Medical College, Surat.
That's excellent, isn't it? It doesn't matter whether she's she's going to be the queen of soft tissue pathology. So, very good. Right, now this is what we call it, okay? There is another name for it, malignant gastrointestinal neuroectodermal tumor as well. Right, and this is another case that we saw, and now we've seen, a few of these cases, because when you're doing second opinion work, it comes to you as a funnel. This is much more clear, and some of these tumors have got osteoclastic giant cells in the tumor. Now, you haven't seen this, and this is a 29-year-old female, nodule in the broad ligament discovered at cesarean section for obstructed labor. And the cause of the obstruction, and that's why she had the Caesar, was a large uterine mass, possibly a fibroid, okay? And this is the nodule. You can see that this is omental fat, and this is the nodule, yeah? Looking at it carefully, I hope you are. Particularly with respect to where is this nodule situated. Diagnosis? Yes, this is deciduosis of the peritoneum, okay? And if you are not aware that this is what decidua can look like, so again I heard only female voices. What's happened to the men? Huh? Nothing. So they leave the women to win the prizes, whether it is the the iPhones or whatever else, huh? And the men are being left behind. Please, come on. All right, so now this is case number 5, and this is a 53-year-old female with a large cystic mesenteric mass, multiple liver metastasis, and the biopsy of this mesenteric mass was done. So obviously it's malignant. I'm sorry, it turns out to be quite blue. It's not so blue over here. So what is it? It's a tumor, yes, which is spindly, as well as non-spindly. Okay. Yes, I can hear some male voices whispering. Liposarcoma, and all the males said liposarcoma. I never heard a single female voice saying liposarcoma. All right, so let's see now whether this is a liposarcoma. It's epithelioid and mesenchymal, and it's also spindly, yes? It's malignant, there are liver metastases, it's primary, and we need ancillary tests. But to do that, we have to know, at least construct some kind of differential diagnosis. So here it is. Malignant tumor with a myxoid appearance, cells with an epithelioid and spindle cell appearance. So what is the differential diagnosis? Epithelioid GIST, epithelioid smooth muscle tumor, P-coma carcinoma. I don't see any liposarcoma over here. Okay? You know of any liposarcoma that has multiple liver metastases, young men? Huh? Because it's only the men who said that. Huh? I would have said young people, but I had to say young men because I never heard a female voice in the liposarcoma. Okay. So you do all the tests, and here is CD117, which is strongly positive, DOG1, which is strongly positive, CD34, which is strongly positive. It is an epithelioid, gastrointestinal. Now, why am I showing you these cases? Just for fun? No. It is, see, somebody thought it was a liposarcoma. And it isn't a liposarcoma. You don't get multiple liver metastasis. And even if you did, liposarcoma has to have lipoblasts. And what are lipoblasts? The nuclei have to be indented by the fat within vesicles that are bursting inside the cytoplasm of these cells. This doesn't have it. It's just a vacuolated multivesicular cytoplasm. And you can see that stuff is pouring out into the myxoid, into the stroma, producing a myxoid change. So this is not a liposarcoma. There was not a single lipoblast in this lesion. And you can get things like this, spindle and epithelioid, that are actually GISTs. And this contrasts with the previous case, which looked epithelioid, which looked clear cell, and people thought that it might be an epithelioid GIST, okay? So, now this you haven't seen. 34-year-old male had an excision on the lesion on the plantar aspect of the foot. Specimen was received in these multiple brownish and hemorrhagic bits. It was a pretty big chunk of almost like curetted material. And here you see it. See this? The bones are clean. There's nothing in the bones, but this is the tumor. And this is it. Anybody gets this diagnosis, no, or comes close to it, I will personally give you but it is a spot diagnosis. Okay, here you see this huge dilated vascular. Okay, and for once this LED screen is making me happy, because you should be able to see what I want you to see, and it's there. What's the diagnosis? What? Giant cell tumor. Again, it's a male voice. Male voice. Hey, what's wrong with you guys? You get this in GCT, is it? Huh? This you get in GCT. You want to look carefully at what this is? I'm showing it to you now. Look carefully. I've got it for you in higher power, and I've used the word, just like the word shard. You know, cartilaginous tissue that's like shards that have broken into irregular bits with pointy ends. This is grungy, which means grimy or dirty. You know, when you get a lot of wet dirt, that is what this is. Yes? See, did I not tell you that she's the queen? Yes. When we saw this, we said there's some history that we don't know. All right? And then we started going through a history. And it showed that she had generalized arthritis, early onset diabetes mellitus, history of back pain, etc. And then we said, bring your biochemical reports. And she had had persistent hypophosphatemia, which nobody noticed, because they were doing the test for the calcium. They weren't bothering about the phosphates. Hardly anybody looks at phosphates unless you're an endocrinologist. And this is what it is. It's a phosphaturic mesenchymal tumor, okay? That's because the tumor cells elaborate this FGF23, which prevents the renal reabsorption of phosphate. So you lose a lot of phosphate in your urine. And this is what you have, varied morphology. You get it up in the nose and in the paranasal sinuses or in the soft tissues of the head and neck. And there it tends to have a more, storiform pattern. It might look like a hemangiopericytoma, but it can occur anywhere in the body. And it has an angiogenic component of one sort or another, hemangiopericytoma-like, or in this case, like huge vascular structures and osteoclastic giant cells. Okay, it's also known as oncogenic osteomalacia. So Vasudha, I owe you, a prize. She's very good, is Vasudha. So somebody should, sort of give her a big hand. So good, that's that. And we come now to the last case, and I will be finished. And this is a 46-year-old male who had a left pneumonectomy. Okay? Now let's see how this shows up on the screen. That's a bronchus, you can see that. Okay, so this is in the lung. And you see that there's nothing much to see at this part, except that it is a very cellular tumor. Right? That's how the cells look like. You begin to see that there is some spindling, storiform, whorls, yeah, seems to be at the periphery, but towards the center it becomes sheet-like, almost syncytial. When do you say it's syncytial? See, you can see this. You can't see individual cell borders. Here you can see nice spindle-like cells forming the whorls. Yeah, there you can see the spindle cells. But when you go towards the center, you see that, yeah, some of the cells have, you can see a cytoplasmic border, but in many, like here, you don't see a cytoplasmic border. It tends to sort of form a kind of syncytium. Diagnosis? Anybody? Pulmonary? Langerhans cell histiocytosis. Did you see any grooves? in 1 or 2. That makes it very hard, no? With 1 or 2, it's like what Dr. Kane said, that you can see grooves anywhere that you want to see it and call something papillary carcinoma on aspiration cytology. You have to be convinced. You're not very sure. Anyway, but she's not far from the truth. So, we can go through this usual story. It's malignant, yes. If it's benign, I've written malignant, how can I be not sure? That top malignant is not there, it's not sure is there. Ancillary tests, okay? It's a distinctly world. When did Langerhans cells become world, okay? Mesenchymal tumor. Did you see any eosinophils? There's not a single eosinophil. Within the lung, encircling the bronchus. So it's in the lung. Is it an intrapulmonary thymoma? Possible? It's possible. Okay. Is it a pulmonary meningioma? Yes, I heard somebody there saying yes. So you have to figure it out, no? Is it one or the other? So you do. It should be, if it's an intrapulmonary thymoma, it should be this. If it's meningioma, it should be EMA. And then you do all the rest for the soft tissue tumor. And lo and behold, it's EMA positive, very strongly EMA positive. So what is it? Intrapulmonary meningioma? I did a PGR, and the PGR is negative. And you will say, so what? PGR may be negative. So what do you want to call it? Intrapulmonary meningioma? No CK, no SMA, no desmin, no CD34, no S100 protein. So what next? Look at the histology again. Look, please stare at it. And then you ask, what is this diagnostic clue? And there is one. There is one, and it's not the grooves. Lymphocytes. Why so many lymphocytes in the tumor, but no plasma cells? And this is a lesson for all you guys who like to use loose terminology. It just trips from your tongue. I tell my students, if the word gray, white had not been invented, I wonder what you would do about describing tumors. Every tumor has got a gray-white appearance. Similarly, every tumor is infiltrated by lymphoplasmacytic infiltrate. Whether it's a tumor, it's inflammatory, anything. Lymphoplasmacytoid. You never bother to see, are they really lymphocytes? And are they really plasma cells? And there is not a single plasma cell. It's just full of lymphocytes. So, what immunohistochemistry? Now you do a CD21, you do a CD23, you do a CD35, and it is an extranodal follicular dendritic cell sarcoma. Okay? So that's what it is. They're very uncommon. There's a low to intermediate grade malignancy, can occur anywhere. I think by now we have seen upward of 60 or 70 such cases, okay? And well, we've published in the literature, and some of it is also going to come up on what the RNA, microRNAs are like in these tumors, particularly the extranodal dendritic cell tumors. They are very uncommon. They all finally have a bad prognosis, okay? And look at all the different types of variety that you can get. So how do you make a diagnosis when you see this much variety? And that is, after all else fails, think follicular dendritic cell tumor if you see lymphocytes. And those lymphocytes are all B cells. There are no plasma cells, okay? So many of them go unrecognized. Why? Because people don't look for this lymphocytes unaccompanied by plasma cells. And I would say lymphocytes are often regarded as background noise. You heard, no, about signal and noise? Yes. For extranodal follicular dendritic cell tumors, they are an important clue. So I'll end this by saying, what the mind does not know, the eye cannot see, like the first two cases that we had, angiomatoid 5. If you don't know about it, you're unable to make the diagnosis. Also, it's pseudomyogenic, okay? But there is a corollary, and that is for the mind to know, the eye must see first, yes or no? So, can't go around saying, oh, I don't know what it is because I never saw it before. But if you don't see, then your mind cannot know. All right? So, I would say thank you very much for everything. I must thank Prashant and all the organizers of this wonderful GAPM. I was just telling Prashant that he has gone out of his way, and of course the other organizers, including the president, that you have really gone to great pains to keep everybody happy. Yes, I thought yesterday's party was an absolute riot. And today with the prizes and everything. And I must tell you that the accommodation, Prashant, that you gave me in this, and all of us, I'm sure, was so plush that I didn't want to even sit on that bed. It was so comfortable, you know. So, thank you for everything. I enjoyed every moment that I was over here, the Surti food and everything else. Thank you, Dr. Naik, for being a friend for so many years, and you know, all of you for your hospitality. So, have a good and happy new year.